let's talk about public-private partnerships. So today, there's the challenge is too complex to be able to solve women's health or a solution to help a woman in their health needs without it's for one sector to do it. So it has to be a combination. It has to be a partnership. It has to be collaboration. Where's Blevin? No? Okay. He didn't hear it, but I love that term because it's true. We can't move the needle without collaborating. And today we're going to talk about public and private partnerships and how our two wonderful experts, we have Julie here, and I'm going to let her introduce herself, and Esther. We're going to start with Esther online. And they have been on both sides of the equation, and they're doing some great things. So let's hear about that, and then we'll ask some questions, and then we'll open it up to the audience. So I think we'll start first with Esther. So if we can make her live on the screen. In one moment. Or should we try let's go with Julie. Julie, you're first. Here we go.
So I can see energy is flagging in this room, and I can totally understand that, having been in meetings all day myself. So thank you for participating in this. It's energizing to get out of Washington and to be here around people who care about something that's bigger than politics. So I really appreciate the opportunity. I'm Julie Gerberding. I'm the CEO of the Foundation for the NIH, but I formerly worked for a pharmaceutical company. Before that, I directed the CDC, and before that, I was an academician. So I've kind of been in all sectors, and I've known about partnerships and public-private partnerships for a long time. If you don't know what the Foundation for the NIH is, it's a nonprofit, non-governmental organization, but it was created by the U.S. Congress to support the NIH because it's really hard in America for organizations to work with the government directly. So we have kind of most favored nation status, and we get to participate in fundraising and supporting and raising money to support projects that NIH can't do alone. We are really bridges to breakthroughs, as we like to say. We take the best scientists at NIH and connect them to the smartest people in academia with the smartest people in the life science companies. And more recently, we are thinking of these partnerships not just as private-public partnerships, but as private-public patient philanthropic partnerships. So it's the quadruple P, and that's really our secret sauce. So that's the FNIH. I want to make 3 quick points in my introductory comments. The first is that from where I sit in my long experience of struggling with women's health issues, I believe that women's health disparity is a wicked problem. And by that, I mean that it's a complex problem. It's big. It's really hard to solve. It takes resources, time, and patience. It's a problem that's characterized with lots of diverse stakeholders, all of whom have their own agendas and their own points of view. And it's a problem that is based in human values, in culture, and in some of the things that divide us, as well as the common interests we have in success. So that's the first point. The second point is that it takes a wise crowd to solve a wicked problem. And by wise crowd, I mean a diverse crowd that includes points of view from a variety of different sectors, or in our case, countries, organizations, individuals, skills, et cetera, et cetera. And it's only by bringing this wise and very diverse crowd together that we can begin to find the commonalities, share experiences, and really move forward. I have some examples in my own professional career, some stories, if you will, not statistics, that kind of illustrate that point. One of the things that has crossed over between my various walks of life is maternal health and maternal survival. When I was at San Francisco UCSF during the early days of AIDS, we were very concerned about mothers with HIV infection as well as their babies. So got involved in an NGO in Africa that was specifically addressing the risks to mothers with HIV when they become pregnant, as well as, of course, the risks to the babies. Fast forward my time at Merck, when we had a nonprofit activity called Merck for Mothers. And Poppy was here this morning. I don't see her in the audience now, but she's leading that effort in India even now. It's a $750 million nonprofit, non-commercial activity to try to reduce maternal mortality from preventable causes. And one of the great things that happened there was we discovered that a company in Switzerland called Ferring Pharmaceutical made a compound to stop maternal bleeding called carbetocin, which could be formulated to be heat stable, meaning you didn't need the cold chain that you need for oxytocin, which is the standard of care. So we supported a very large clinical trial to show that this heat-stable carbetocin was non-inferior. It's now in the WHO essential medicines list and is being distributed to women in areas that don't have access to good birthing practices. So fast forward to my day job now at FNIH, and when I arrived, they were just finishing this wonderful NIH-supported study in collaboration with the Gates Foundation and many academicians around the world to show that a single dose of azithromycin during labor reduced maternal sepsis by 35%. That's the so-called A+ study, which was in the New England Journal. Again, a fantastic private-public patient partnership. And then finally, FNIH now is just embarking on another big partnership to address preeclampsia, and particularly to try to develop better early diagnosis of preeclampsia so that you could intervene before there's maternal catastrophe. So I just bring these examples up because I think it really leads to my third point, which is what constitutes a successful, wise crowd? In a word, women. Now, it does not mean that nothing good in the world can be done without women, but it does mean that there are aspects of collaborative leadership that really are based on of sensitivity, perceptiveness, the ability to bring people along, to listen. There's also a role for transactional leadership and other leadership styles as well, but I do think we need to think about when we're assembling a partnership, what's the composition of the group? Because it's really the group that's as successful, not this great leader or this great participant, but do we have the complex of all the different points of view and skills and leadership competencies that allow us to find common ground and slowly but surely move the agenda forward. Thank you.
Very nice. Thank you. All right. We'll cover a little bit of that in the questions, but Esther is live, so we will we will put her on the screen. Welcome, Esther.
I'm visible. Good. Hi. Thank you, everyone, for having me. And wow, what a beautiful panel before us, and what an honor to be on the call with or panel with you, Dr. Julie. My background is I grew up in Belgium, Dutch by nationality, but I moved to East Africa 15 years ago. I'm a midwife by training, and I worked clinically as a midwife over 10 years, both in private and in public healthcare facilities, mostly in public. So I've been one of the people that benefited from a lot of public-private partnerships and really actions that really helped a lot of mothers. Currently, I'm the head of growth and strategy at Africa Health Business, which is a Pan-African consultancy advisory firm really looking at strengthening healthcare through the private sector lens. Now, what does that really mean? It is making sure that private sector organizations really align with governments, with regional bodies to ensure that what is happening is aligned with the need and the strategy locally. I think for me, the real bridge that I'm bringing is that frontline reality with system level solutions, which I really am blessed with, that I have both insights in that. I have been one of those people that saw a lot of donor organizations come into a hospital, set up a few projects, that when the funding went, the project went. This is also one of the big reasons why I believe in public-private partnerships. I believe in sustainability and the build on that. I think women's health in general is underfunded, and especially related to or relative to its impact. Many women's conditions rank really high in burden, but low in funding. And even small increases and changes, and even small projects like Dr. Julie mentioned, not small research, but like small changes, like 1 dose of azithromycin for a delivered mom, 30% reduction in infections is huge. And you see those changes. And as Gabriele in the previous panel said as well, the economic burden for poor women's health is huge. The productivity goes down, the GDP makes losses because we are less productive as women. And closing that gap could really make a change. $1 invested in a woman is $3 in social and economic return. And not just for that woman alone or for that generation, but for multiple generations. So I think we can't deny the importance of public-private partnerships within women's health. It can unlock innovation, it can unlock financing, it can reach way beyond what governments and private sectors can do on their own. But together, it's huge. There's an African saying, if you want to go fast, go alone. If you want to go far, go together. I think it's definitely a building stone of what we can use under public-private partnerships. And I think it's been highlighted even, I think, in the previous panel, women in workforce. I think if you want women in workforce and in leadership position and in decision-making positions, you need healthy women. So it starts with healthy women and making sure that from the beginning, from birth till end, they have good health. And again, we talk about public-private partnerships for many different reasons. Why? It was mentioned before, bridging gaps in resources. There isn't enough resources, especially at the moment with the changing funding landscape and the capacity constraints. We really need to look at how can we partner to make sure there is diverse funding streams. Innovation and expertise, it was mentioned before. Private sector can bring innovation, can bring technology, digital solutions. It doesn't need to be copied. It doesn't need to be reinvented. It needs to be implemented together with governments. And as Dr. Julie said as well, patients, grassroots organizations, they need to be part of this. The stories need to be part of it to make sure that the data, the stories, and the public-private partnerships work together. Accelerating impact, making sure, it's an interesting one with health, especially because we need long-term investments and we need immediate results, where actually health often needs long-term investments and the slow results. But we almost need both all the time. For example, maternal and newborn health, maternal and newborn mortality rates. They really need long-term investments, but they need fast results because we want those mortality rates to go down. And then again, public-private partnerships, what do they help with? Shared risk, shared reward, because it's reward as well. It's not just shared risk. Health interventions are risky and they're resource intensive. So public-private partnerships, we distribute the risks, but we also distribute the rewards. For private sector, it's acknowledgement, it's measurable outcomes, it's also even maybe financial gain, but it's for public sector, it's health gains. And then the sustainability. By creating public-private partnerships, the solutions are not only funded, but also really embedded in the local health system. And I think that is also something I will keep hammering on, is making sure it is part of the local system. But then again, one size for public-private partnerships, and I'm sure, Dr. Julie, you will have heard and seen that as well. One size does not fit all. Every public-private partnership looks very different in any other context. And also, depending on the strategy of a country, there is very different priorities. And that's fair. Different countries have different levels of maturity and therefore different levels of needs. Therefore, the public-private partnerships will look very different. And there's different opportunities. There is service delivery partnerships. There is infrastructure and equipment public-private partnership. There is digital health and telemedicine public-private partnership, supply chain and logistic, capacity building in the health workforce, innovation and research, and go on and go on and go on. But for me, I think, and I'm sure I'm not the only one, lasting impact will come from working across sectors, government, private sector, donor organizations, but not to forget, as Dr. Julie says, patients, civil societies, women's groups. If we do not include them, it won't last. The key is to map the strengths, build trust, and grow partner capacity so everyone can deliver. And as civil society partnerships connect directly with women and grassroots, ensuring no one is left behind. And if you would leave those out of the equation, the long-term collaborations will not last. So again, to end my beginning or entry talk, is for me, I want to make sure that I bring across that private-public partnerships are not just contracts. They're not just a contract between a government and a private sector entity. They are trust, alignment, and shared values between multi-sectoral organizations and societies. That can be locally, that can be interregionally, but women's health should be at the center of these public-private partnerships as a foundation for a stronger society, but also to make sure that these women can grow from young to old and become these leaders that we so desperately need.
Wow. Very nice. Thank you, Esther. Yeah, so many things are popping in my head right now to say, but I'm going to start with a question. I'm going to go to you first, Esther, and then I'll go to you. And by the way, thank you. Both are esteemed, and Dr. Julie and I. They're very kind to let me call them by their first name, so thank you very much. But Esther, what's the single most effective move you've made to gain traction in women's health in your current roles, or maybe just let's talk about Africa a little bit. What? And it's more about relationships that you're forming, not necessarily only partnerships, right? And that kind of mirrors what you just talked about. Maybe you could go a little further for us.
I think it's also something that we look at when we do business, right? What do we say when we do business? People don't do business with an organization. People do business with people. And I think that is why the most effective way, not just for me, I think for everyone else, but what I've seen works the best is really to make sure is identifying the shared value for all the stakeholders from the beginning. So what is needed from both sides? Be honest about that, not both sides, from all sides. And this is something we keep saying as well. Even I catch myself, both sides. It's not just the private and the public. There's so many more stakeholders involved in this process, and we need to have them on board from the beginning. A grassroots level organization cannot just come halfway through the project. It needs to be there from the beginning. We need to understand what is the need, what is the pathway, what is the gap, what is the win, and focusing the designing of these programs where public stakeholders achieve policy or system objectives. Private stakeholders see operational, reputational benefits and tangible impact and have increased access to health. But work communities or end users need to gain from this, and understanding this whole map creates mutual wins. And I think having that from the beginning, that clear description, is for me that's where I've gained the most traction. But it's not that easy because people often, it's the same as I always say, your impact evaluation is often done at the end, and then people say, oh, we should have done process evaluation, which should have started from the beginning. it would have been so much better if we would have had a baseline. I think it's the same for public-private partnership. Have that baseline and the values, the needs ready. And I think that's where I've gained the most traction.
Thank you. Julie, could you provide an example? It's already on. Oh, you turned it off. Okay. Single most effective move since you joined your current organization.
Yeah, as Esther has said, like there's no one size fits all here. If I have a secret sauce, the thing that I turn to when I have a dilemma about how to build that alignment or identify those shared values is listening. And I know that seems like a very soft thing, but usually the solution exists, but you can't always get it out of people if you're not willing to do more listening and less telling. So it's really about listening rather than it is leading. That's kind of been a pattern through my career, and my aha moment happened a long time ago in the AIDS days, where when I became the CDC director, there were a bunch of people over here who thought it was an outrage. This radical woman from San Francisco was going to be leading the CDC, and then there were some people over here who were outraged because, oh my goodness, that woman is working in the Bush administration. How much of an AIDS activist could she really be? And I couldn't possibly please these crowds, but we had to build an alliance around HIV prevention because our country was failing. And so I just spent a huge amount of time listening to these disparate points of view and everybody in between. And eventually we all got together in the same place. We listened to each other, and believe it or not, we found common ground, which is to say that we need to do more to prevent maternal child HIV transmission, and we needed to go to Congress and argue for more money for HIV prevention, period. Didn't say what the prevention should be, but it just said we agreed on that and let's move forward in that way. That was an aha moment for me because I never thought I would be able to build any kind of connectivity between such widely diverse groups of perspectives. And yet by listening, and everybody listening, not just me, we found some things that we could mobilize on that I think helped make a difference in the early days. So I've always tried to carry that forward.
Nice. That's a great example. Let's talk. We talked a little bit about political. I'm going to put this back to you. How do you future-proof a public-private partnership, against political and funding shocks?
It's a couple of
Maybe
things.
Current environment,
it
possibly.
might be on my mind right now, yes. There's a couple of things to say. First is, as Esther said, and as was pointed out in the last discussion, statistics and stories both matter. So you need the facts about the problem you're solving and the progress that you're making toward getting the result that you're aiming for. But you also need the stories of the problem and the stories of your success, so that you not just start off with a healthy coalition alliance, but you nurture it, you support it, you give people ongoing reasons to believe so that they can help sustain the momentum. I think the second piece of that is that you need to get more legs of the stool. So when I say private-public, patient, philanthropic partnerships, that's one part of how you bring a coalition together to really get success. But it's also a sustainability strategy, because you need the advocacy and the wisdom of the people with lived experience. You need the philanthropists who have money to spend but don't really necessarily know the best way to put it to good use. And then you have, the more traditional government and private sector partners who have their own agenda, but who also recognize the leverage that a partnership can create. But for any organization to rely on any one of those dimensions, or any two of them really, is not necessarily sustainable. When I came into my new role at the foundation, I realized very quickly that we essentially had little philanthropic leg on our stool. And boy, am I glad we started the process of investing in that aspect of our support, because we really need that now.
I love the 4 Ps, by the way. I think it should be the 4 Ps and not the 3 Ps. So it's started now. So Esther, How can you share how do you future-proof? You deal with politics and funding, probably more so on the funding side of things, don't you?
Yeah, and I think I agree, by the way. Dr. Julie's right, it should be 4 Ps. And I think another thing I want to highlight, the listening, it sounds easier than it is. It's not because of not wanting to listen, but real listening, not just at the beginning of a project or a public-private partnership, but during and re-evaluating. It's a very difficult thing because it is holding so many stakeholders. But for me, what is really important and what creates a future-proof public-private partnership against shocks is really creating resilient initiatives. And how do you do that? Is by building local ownership within these initiatives. So an example is the partnerships that are embedded within the existing health systems. I'm a huge fan of the International Confederation of Midwives. They are doing an amazing job in putting a baseline down for midwives and working in many countries globally, but I'm going to focus on Africa because that's where my knowledge lies. But it's working together with government institutions, training institutions to make sure that the baseline of these midwifery classes or masters are there. Making sure that the right partners come involved. So, for example, Lardal comes in a lot and does a lot of training. This is a public-private partnership by government training institutions are getting private sector entities in to really create a strong workforce through capacity building, and therefore creating resilient systems that even after the donor funding or even the funding or this project is finished, that knowledge is still there. And creating that local ownership by governments, so making sure that governments own this project is crucial for me. If there's no local ownership, it's not listening, and it's pushing a public-private partnership onto an ecosystem which will not work easily. So yeah, I think that's my main future-proof plan.
Okay, well, let's continue with the future-proof. What would you say in 10 years? I'm going to go with Esther first. We're just kind of going back and forth. What would you think success looks like for these relationships that are being built beyond financial ROI? Now, I realize part of the goals is the ROI, right? But we've been talking a little bit outside of that here, and I'd love to explore that just a little bit more.
I think it should not longer be seen as an add-on. Public-private partnerships shouldn't be a one-off or a few in a society, because even in Africa, if you look, it's not many countries that are really front runners of private-public partnerships. Morocco, Egypt are really strong in it. Rwanda is getting bigger. But it's still a growing thing. But if you think about it, 50% of the healthcare in Africa is actually private, and 50 about average, right, is public. So it's not going to go away. So these public-private partnerships should only grow. So for me, I really want to see in 10 years, it shouldn't be an add-on. It should be a continuous integrated system into the national health systems, in the ecosystem, to sustain that impact to scale. And again, that is trust. I think if I look back at 10, 15 years ago, having public and private sector in one room was already hard. It would be behind closed door, where now everyone is much more open and discussing these system issues or health system strengthening issues together, which is great. But for me, it's really looking at it that it's not an add-on, but it's a continuous.
Thank you. Yeah, I really appreciate your point of view on that, Esther. And I guess I was thinking more in terms of the outcome and what would be different in 10 years. I always say that, not knowing what to do about something important is really frustrating. But not doing what you know is tragic. And I think in the area of women's health, we have gaps in both of these dimensions. We are not doing the things we know need to be done that actually work. We are not addressing the structural issues. We are not measuring and holding ourselves and people accountable for those problems. But you know what? As a person who's working closely with the NIH, there's a lot we don't know. There's a lot we don't know about women's health. There's so much we need to learn about, women's diseases, those diseases that affect women differently or differentially. We're just scratching the surface in terms of what biology tools are available now, but we haven't really invested in what we need to do. My dream in 10 years that we would be halfway through an incredible longitudinal cohort study of women that started, in childhood, menarche, pregnancy, menopause, and all the way into older age, so that we can really understand the life stages of women and what are the biologic correlates. I'm particularly interested in the neuroscience of all of this, but there are many other dimensions as well. And now that we understand now what happens with the X chromosome when it gets all tied up in a knot and becomes immunologically relevant, and that is driving a lot of autoimmune disease. Those kinds of things weren't known 10 years ago. So we're just tapping into some of the biology that will really unlock the secrets here. But we've got to invest in it, and those kinds of studies, as we learned from the original women's health study, are expensive. They need to be global. They need to be inclusive of women at various walks of life, at various life stages. And I know that this isn't the time to necessarily go to the Congress in the U.S. or the WHO to get money for something like that. But when you think about what's at stake and what the value of having what we need to know, I think it would be an incredible investment, and probably more important than even going to the moon.
Wow. Okay. Can you all hear me? Okay.
That was Elon Musk.
That was good. That was a really good. That was pretty funny. Thank you. She'll take the tips at the door. No. So, what's been really interesting about this conversation is it kind of ties into a session we had earlier on innovation. And we tend to rely on people and companies and startups and studies to actually drive forward what it should be common practice and common understanding of the issues that you need to create these partnerships for the future. So we need to not just treat innovation as a little pocket over there. We need it to be a part of the whole 4 Ps and continue that growing with creating these relationships so that you can make those innovations go quicker. You don't have to wait so long. So all the things and how you impact others too, as far as patient understanding, their literacy level, all of that comes in with equity. Okay, so we have a little bit of time. Can we get some questions from the audience to our 2 experts?
Okay. Good afternoon. My name is Sharon Olago. I'm from Kenya. And I've got a question in terms of PPPs. I run I wouldn't call it a startup anymore. It's a company, medical nutrition company that is integrated into hospitals, both private and public hospitals. Now, the first thing I would love for you to respond to is, now with the pullback of USAID, I feel like this is quite, as bad as it has been, it's also quite a good opportunity for private sector to integrate itself, and especially for women-led innovations to find themselves in there filling in that gap. So what would you advise, especially this room and women entrepreneurs out there, what do you think we need to do in terms of filling in this gap? Because we will speak about the political aspect of it, and I know the environment kind of pisses off everyone, but I think this is more of an opportunity than anything else, especially in Africa where out-of-pocket payment has been quite a big issue. And I would say the assistance of USAID to some extent has also been, I would say, a bit of a hindrance for getting some of us in terms of innovations in health to make traction. But now there's an openness of government to actually partner with us because they really don't have an opportunity. They don't have they need someone to fill in this gap. So what would you say about this? Thank you.
Esther, would you like to take that?
Yeah, I just quickly wanted to ask, is the medical nutrition company in Kenya or across Africa?
It's in Kenya, Lisha Living.
Yeah, maybe we should meet up in Kenya as well. But it's a difficult one, especially at the moment with not just USAID pulling back, but also the Social Health Authority in Kenya that has just changed. So for the people not aware in the audience, the Kenyan Social Health Insurance or the National Health Insurance Fund has changed to the Social Health Authority, which is a new system which is brought on a huge change, but has increased the contributions we need to do as people, but also has increased, sadly, the out-of-pocket payments. So for you at the moment with the medical nutrition company, I think it is a very difficult time because the social side, the public side is I'm sure not really refunding easily, and the private sector, I'm not sure how that goes there, but for me again, it's localization, it's ownership. So government does need to be on board, and I think this needs to come into the strategy. And it's very interesting to see because I'm working a lot with different ministries now, and what is happening is that because the USAID has pulled back, where there was used to be influx of medication, vaccinations, etc., that stopped. Governments have to now really understand what they need. And so this is a time, in my opinion, to really knock on the government's door because they are.
The first one, what one important message would you give to women students in medical informatics, image-guided surgery, and diagnostic students? I support two amazing faculty researchers whose women students go all the way with them from undergraduate to postdoctoral education. I'm attending from Queen's University as a research support coordinator.
Not entirely sure I completely understand the question, but I think that this speaks to the evolving role of agentic AI, meaning using artificial intelligence and data sciences as a tool to augment the care and practice of medicine, and that we need people who are trained and skilled in understanding the value and the limitations of those tools. I will disclose that I'm on the Mayo Clinic board, so I'm very much involved in this kind of effort as it's being practiced in that medical institution. But what I've seen so far really reveals the incredible promise of applications that augment the value of the provider and the patient interaction, but certainly, in my view at least, don't replace it. But at the same time, we need students and trainees who have been brought up in that as part of their core curriculum, so they recognize the challenges of AI and they recognize the biases and the aspects of it that have to be taken into consideration when we identify the potential utilization. Having said all that, we're just at the very beginning of this, so we better get serious about bringing people along fast because it's here and people are using it and it's going to become an even more relevant part. And I think globally, these types of tools will be very helpful, particularly the telehealth tools. I'm a graduate of a medical school in Cleveland, Ohio, that already has remote surgery training and use of three-dimensional learning expertise, so that everything from how to load and transport someone in a fake helicopter all the way to robotic surgery. So it's happening, but I don't know that. I think right now it's sort of a side thing in most medical curriculums, and we need to bring it mainstream. I don't know if that answers the question, but.
Yeah, I think so. I mean, that also warrants the idea that we need our doctors and our nurses and our medical professionals trained more in women's health too along the way.
That's a good point. Yeah. Your microphone is.
Describes herself as a DES daughter, DES. So it says, in the light of recent media attention in the United Kingdom regarding dithylstilbestrol, DES, would this be an opportune moment to establish a collaborative alliance or partnership focused on the broad spectrum of health effects resulting from DES exposure?
If there's an opportunity, the simple answer is yes. I actually thought there was a collaboration that was looking at that issue, so I would have to defer to someone who has obstetrical and gynecologic training, because I assume that there were already investigations in progress that were sort of linking people. What might be missing is sort of the life stage dimension of that, rather than just the, you have the exposure, you have an outcome, but rather what happens to people long term and how is it managed effectively. But I apologize for not, I'm an infectious disease doctor.
We have one more.
Thank you. I'm not sure if I should start off or not. So hello, my name is Marie-Ange. I work for Solid Africa. It's an NGO based in Rwanda, and we're very focused on nutrition, and also very focused on nutrition for mothers in public hospitals. So we work mainly in public hospitals. We do have a public-private partnership with the government of Rwanda to expand nutrition as part of healthcare all over the country in the next 5 years. My question is, how do we go from having a public-private partnership that is in place to now transforming that into policy? Why? Because in Rwanda we have universal healthcare insurance, but meals are not included, so nutrition is not included. Our work now, what we want to do over the next 5 years as we have this PPP with the government, is how do we achieve policy change so that nutrition is included into the healthcare insurance just the way medicine is, because we believe food is medicine. So how do we get to that next step in that PPP that we already have? Thank you. Any insights? Yeah.
Esther, would you like to?
Community level all the way up, using the data, what you're doing now, showcasing this to the ministry, I'm sure this can change to policy. Because if the data is speaking, policy will follow, especially in Rwanda. So I think there's a huge opportunity for you if you are doing on data collection. If not, then I would definitely collaborate with certain research institutions, universities, to make sure that that data is collected in a way that makes the outcome showcase to the Ministry of Health what the value is of it. And I'm sure the next step will be very easy, especially in Rwanda.
Great. Okay, so we have time for just one last thing, if that's all right. So I'm going to go to you, Julie. This is not planned. Just kidding. Well, it isn't. But if you could talk to a policymaker, doesn't matter. You don't have to worry about any. You just get to have a frank conversation. What advice would you give them to better women's health in the future in dealing with the private sector? What would you tell them with all your experience that you've had?
Well, in my fantasy life, I think I would like to sit down with that person, their mother, their wife, and their daughters, and have a conversation about the status of women and the opportunities to improve women's health. Because I think until you really make it real, it's really hard to just talk about data, and that's why stories are important. But there's no more powerful story than the story of my family and what it means to the women who I care about.
That's great. Esther, would you like to share your thoughts of what you would
How do you follow that? I totally agree. But for me, I would, and I think it aligns with what Dr. Julie says, but it's really encourage the policymaker to invest in trust and alignment of all the stakeholders first. Don't try and create a policy before you have that alignment and trust first. If you don't have that, the policy is not going to be as effective, I think. So for me, that would be something. But then again, what Dr. Julie says, sit together with all the partners, listen, understand, with all families, which often creates a huge crowd. But yeah, trust and alignment first.
Well, thank you so much for your insight, your input, and your examples, your new term. And I really appreciate your willingness to meet with us today. And guess what? You get a break now. Oh, wait, we don't get a break. I'm kidding. Sorry. I thought we had a break after this. We have one more session. So I'm going to hand it over to Irene. Thank you so much.